I would like to speak on the perioperative management of patients with hemophilia that are not complicated by inhibitors. And then one of our senior registrars, Tomek, will speak. He will actually show you 3 cases of surgeries that we've performed. And then last but not least, Mohammed Karoudia will discuss the perioperative management of patients with hemophilia that have been complicated by inhibitors. And I'm also looking forward to his talk. So without further ado, I'm going to share my screen.
I don't think you have to be in a hurry because people are still joining every few seconds. So
good. Can I just confirm that you can see my screen and that it's in presenter mode, Estelle? Estelle, can you see my screen?
Sorry, I can't see your screen. I can see you. So I cannot see your screen. So I think
okay, one moment.
If somebody disagrees with me, they can tell me.
Okay, I'm just going to do that quickly.
That's great. And it's not yet in yellow. That's perfect.
You can see it now.
Great, now we can see it. Yes.
Okay, I'm going to stop my video and then I'm going to do this presentation. So first of all, I didn't show it there because I thought that this is a nice background actually to use when I just do this discussion. But just to again tell you where I'm from so that you can have the whole picture. It's University of Pretoria, of course, and the National Health Laboratory Services. And as you can see, the hospital that we practice is the Steve Biko Academic Hospital. So I have no conflicts of interest to disclose related to this presentation, but I have disclaimers. And the first disclaimer is that I acknowledge the presence of experienced members in the audience that have much more experience than I do in terms of perioperative management of people with hemophilia. So I acknowledge that. And the second thing is that I'm not going to speak to products that are not available to us in this setting. As you can see, the Alprolix and Eloctate, these extended half-life recombinant factor 9 and 8 have been registered and approved by SAHPRA in 2020, but they are not marketed in South Africa. And while they are used in the context of elective orthopedic surgery, it's something that we're not going to discuss in this presentation. So the outline is briefly to look at the team, to look at the hemostatic agents, and then the plan, which is more or less hemostatic plan, because that's the most important, I think, component of the plan. Something about pain management, thromboprophylaxis, and then concluding remarks. So I think the first thing to appreciate is that all elective and basically surgeries in people with hemophilia should actually be done and be overseen by a multidisciplinary team that has experience in terms of management of patients with hemophilia. And I think the first thing that I would like to highlight in this scheme is basically the integral part that the patient and the family plays. So if one thinks about that as what needs to happen with the patient is that the patient should understand the planning process, the patient should understand the surgical procedure and the outcomes. The patient has personal goals and concerns and fears, and all of those things should be discussed between the different members of the multidisciplinary team, and those fears should be allayed. And then the patient expectations are central to the whole process of surgery. It should be communicated, it should be recorded, it should be understood, and it should also be managed in that context by the members of the multidisciplinary team. The second important person is the multidisciplinary team coordinator. And this the coordinator can be, and is usually a full-time permanent member of the multidisciplinary team and take the leadership role in terms of engaging with the patient and with all of the other role players or members of the multidisciplinary team. And there should be free communication and flow of information between all of these role players. And what the coordinator is responsible is for ensuring that all of the steps associated with the surgical preparation and the procedure, the way that it's performed, rehabilitation, are executed. So there's also and I'll discuss that in the next slide also, a checklist that the coordinator can use to check that the responsibilities of each of the multidisciplinary team players have been met. I'm not going to say anything about or discuss every individual role player's role, but I think suffice to say that there are things that are important. If we just look, for example, at the anaesthetist as part of this a team member, then we know that we need to have someone that has experience in terms of giving anesthesia to people with hemophilia. So that's important. And also the type of anesthesia that gets applied. So neuroaxial anesthesia is still not supported widely by the World Federation of Haemophilia, and that should be kept in mind when we choose an anaesthetist. This table basically shows you the different roles, not only the different roles, but the different aspects of planning for the surgery, starting with the outpatient planning and ending with basically rehabilitation. There are some of the functions that are unique to certain of the role players or multidisciplinary team members, like the surgeon, that needs to both plan the procedure, schedule the surgery, and then also in the end, perform the surgery. So that's very important. And in terms of that, we also need an experienced operator with meticulous operative technique, because we don't want to end up with what we often call tongue-in-cheek factor 14 deficiency, which is basically surgical technique. The hematologist, of course, very important in terms of drafting and communicating a detailed hemostatic treatment plan. The physiotherapist, important in terms of physical, assessing the physical condition of the patient, doing pre-rehabilitation exercises, and then both preparing and implementing the rehabilitation plan. And then if we think about the hemophilia nurse is almost the person that is coordinating and checking that all of the different aspects come together in terms of a coherent operation. She's liaising with the patient and the family. She's liaising with the ward and the theatre personnel. She's training them, and she's checking that all of the different aspects are being managed and correctly approached. And then I think something that we shouldn't overlook is the central role also that the dentist plays, because the dentist is very important to ensure that there are no periodontal disease and that the patient doesn't become septic afterwards, especially when we talk about joint replacement surgeries. So, and if there are any dental work to be done, it almost constitutes another minor type of surgery that needs to be effected before, if there's a major surgery that needs to happen before that happens. So everyone has their role to play, and the coordinator will have a checklist for every of the multidisciplinary team members, their responsibilities in each one of the different phases of the preparation and the surgery that gets performed. So I think when we look at the hemostatic agents, there's been almost transformation of the scene in hemophilia. Before 1960s, the mortality rates with people with hemophilia that underwent surgery were very high, 25 to 50%. And then as there were advances in the blood product technology, that revolutionized the perioperative management, of course. And then what we've seen is that the mortality decreased with the use of plasma, less than 10% mortality. Then cryoprecipitate in the 1960s, less than 2%. And with the advent of factor concentrates, it went down to less than 1% mortality. And these are the hemostatic agents that we currently have available, both recombinant and plasma-derived factor 8 and 9 preparations. And then desmopressin, of course, antifibrinolytics in the form of tranexamic acid, adjuvant agents like fibrin glue, and then non-replacement substitution therapy like emicizumab. So when we look at factor 8 preparations that we have that is being marketed and available, hemosolvate, as we know, is the intermediate purity factor 8, plasma-derived. Octanate is a pure factor 8, also plasma-derived, and then the recombinant Covaltry that recently replaced Cogenate FS, and then Xintha of Pfizer. And if we look at these products, both the plasma-derived and the recombinant factor 8 concentrates are available and should be dosed similarly. So 1 international unit per kilo of factor 8 clotting factor concentrate will increase the factor 8 by about 2 international units per deciliter. And that is similar in patients with that receive recombinant or plasma-derived product. In fact, literature suggests that there's no difference and that the recovery after infusion with recombinant factor 7 may even be a little bit higher than that of plasma-derived. And we can easily calculate what the dose should be. And the equation that you use is the desired rise in factor 8 multiplied by the patient's weight in kilograms multiplied by 0.5. So when we think about the plasma pharmacokinetics of factor 8, the average clearance, and I must say I took this from the textbook of Haemophilia, second edition, and that the author of that chapter is Björkman of Sweden, and he's done a lot of work in pharmacokinetics of hemophilia. And the average that they considered of clearance is 3 milliliters per hour per kilogram of body weight of factor 8, with a range of 1.5 to 6, and then elimination of life of about 8 to 23 hours. And I think that this is important because this is something that we apply in our calculations also when we prepare patients for surgery. And in terms of the factor, the factor 9 products, basically we have 2 products. We have no recombinant product in South Africa that is marketed and approved by SAPRA, but we do have Hemosolvex, which is a PCC containing factor 2, 7, 9, and 10, and then Octa9 from Octapharma, which is a pure factor 9. And I think which is important is that when we consider the context of surgery, where there's also prolonged therapy at high doses, and the risk of thrombosis because thrombogenic potential, we would like to stay away from a PCC and move to a product containing only factor 9, which is more appropriate, and that's also a recommendation of the World Federation of Haemophilia in the 2020 guideline. 1 international unit per kilo of plasma-derived factor 9 will increase the factor 9 level by 1 international unit per deciliter, and you can again calculate that. So the dose equals the desired rise in factor 9 multiplied by the patient's weight in kilograms. It is not the same or similar for recombinant factor 9. So the clearance of recombinant factor 9, of course, is higher, and the in vivo recovery of recombinant factor 9 is also lower. So when you use this equation, for example, for recombinant factor 9, you are going to divide this value that you get by 0.8, and that will be for adults, and by 0.7 for children. So this brings us to desmopressin. Of course, this is a synthetic analog of vasopressin that boosts plasma levels of factor 8 and 9. So preformed factor 8 and von Willebrand gets released from storage in white blood bodies. And it is mostly used for minor invasive types of surgery in patients with mild hemophilia A. So the baseline level should be between 5 and 40. And then you can use it also in patients that are carriers, of course. So it's very helpful for the use in patients with hemophilia A carriers. And what we often use is for dental extraction. But the one thing that I think is very important is that we need to only give DDAVP to people who respond. And at the time when the diagnosis is made of mild hemophilia A or von Willebrand disease, that test dose and efficacy should be demonstrated already. And this can be done by doing a baseline factor 8 level, and then administering either IV, standard dose 0.3 microgram per kilogram, diluted in 50 mL of saline, infused over 30 minutes, or the subcutaneous administration, which give you comparable value, also 0.3 micrograms per kilogram. And then after 60 minutes, at the end of your infusion, or after you've given it subcutaneously, you do a factor 8 level. And what we would like to see is an increase of about 2 to 4 times. And then it needs to be in the range where it will give you hemostasis for us to use it for any type of surgery. Of course, it's contraindicated in pregnancy and in young children and people with arteriovascular disease. So those are absolute contraindications for using DDAVP. Then in terms of tranexamic acid, we know that it inhibits activation of the plasminogen activation, and it can be given intravenously or oral. It's particularly useful in areas where there is high fibrinolytic activity in the gastrointestinal tract, when patients present with menorrhagia, especially carriers of hemophilia, open wounds and dental surgery. And then this recommended dose, IV dose, is 10 milligrams per kilo, 2 to 3 times daily, and the oral dose 25 milligrams per kilo, 2 to 3 times daily. It's contraindicated in thromboembolic disease and hematuria, and it should not be used with factor 8 inhibitor bypassing agents, or FIBA, or PCC. And I know that it is being used when you are in certain series. It has been published that it is being used without thromboembolic events, but you should have a high index of suspicion. There are no recommendations for the use of tranexamic acid in surgery, as far as I know, but it is used extensively, and even in arthroplasty, where it's given IV before the tunica is released and then repeated at 3 hours and 8 hours, and used for up to a week at 1.5 grams 8-hourly. This is a retrospective study that investigated the potential benefits of thromboxane in hip and knee arthroplasty. And what they looked at is perioperative blood loss, transfusion rate, safety, inflammatory biomarkers, and clinical outcomes. And they compared the group that didn't get thromboxane to patients that got thromboxane, and a lower level of tranexamic acid, and they found that there was less perioperative blood loss in patients that got tranexamic acid, less transfusion, and supplemental factor 8 was also less. So you could save on factor 8 by giving it. And then also shown that swelling ratio was less, and surgical joint pain, as you can see here in the first panel, the visual analog scale pain score for patients that use thromboxane or tranexamic acid was much less than the non-tranexamic acid group. And then what they also showed is, in terms of the inflammatory biomarkers, is that for CRP, the CRP was much higher in the non-tranexamic acid group as opposed to tranexamic acid, and the same for interleukin-6. So this shows, and it was a small series of about 16 and 18 patients in the two different arms, that there may be benefit to using tranexamic acid. The last of the hemostatic agents is, of course, emicizumab, and we know that this is the bispecific antibody, and it is used in people with hemophilia A with no inhibitors, and the World Federation of Hemophilia recommends that it can be used for regular prophylaxis. So what it does is basically brings together activated factor 9 and factor 10. And in doing so, it will activate clotting, and it will influence what we see in the PTT test. So I think this is an important thing to mention, and I know Susan Lowe is in the audience. And I think what we need to recognize is that tests that we do in the coagulation laboratory will not be reliable if it is one-stage clotting assays. And when we want to investigate factor 8 levels and inhibitor levels, we need to move to a bovine reagent chromogenic assay. So I think that is an important thing to remember. So this was a case report that was recently published of a man with severe hemophilia A inhibitors that had total arthroplasty of his elbow. He was being treated with emicizumab on steady state. And then preoperatively, he got recombinant factor 8, 4,000 units. And then he had continuous infusion at a rate of about 4 international units per kilo per hour of factor 8 that was maintained over 24 hours before it was tapered. And what they've done is to do one-stage clotting assay of factor 8 pre-surgery, pre-bolus actually, and post-bolus of surgery. And you can see that it gave values of 200 international units per deciliter. If the surgeon then continued and did surgery, it will be a catastrophe, because subsequent to that, they've used the same specimen in a bovine chromogenic factor 8 assay. And they also analyzed it by the human chromogenic factor assay and found discrepant results. So the fact that the actual factor level was less than 1%. And following the infusion, the bolus infusion, it was 137%, and you can monitor it for the first 4 days. So there was also a discrepancy between the human chromogenic factor 10 versus less than 1 international unit per deciliter of factor 8 level pre-bolus infusion. But soon after that, if you look at the first 4 post-operative days, the values were still discrepant, but more similar. And what happens is activated factor 8 has a higher affinity for activated factor 9 and 10 times that of emicizumab, and it replaces the emicizumab, and through thrombin that gets generated actually produce these values and the clotting. So high doses of factor 8 will dilute and displace the emicizumab and give you these results. But what I think the take-home message is that you have to have the correct laboratory technique in the context of the correct patient to give reliable results to act on. So in terms of emicizumab, it can be used in minor surgery, and it can be used without giving factor 8, but you should have factor 8 immediately available, and the dose would then be something like that, 30 to 40 international units per deciliter. That will be your target. Major, if the patient undergoes major surgery, so a major risk of bleeding, you should infuse factor 8 prior to the surgery, and you can also give repeated doses depending on the clinical need. And the target will be 50 to 100 international units per deciliter. And then tranexamic acid can be used together with emicizumab. So what about the plan? And the plan is around surgery. So we always want to plan well, and we want that plan to come together. So we don't want nasty surprises. So the surgery has to have an indication. So the surgeon, together with the hematologist, decide on whether surgery is indicated. And that surgery can either be elective, and which you have time to plan, or it can be emergent surgery, like fractures after trauma or compartment syndrome, or infective like appendicitis. There are things that you need to consider. So the first thing is the previous clinical response to treatment or to surgery. If the patient had major surgery before and responded well to the plan and nothing has changed, that is something that will inform how the hemostatic plan gets drafted. The underlying factor deficiency is, of course, important. Whether the patient has inhibitors, that's important. Associated complications. The complications can be complications that are part of the natural history of this disorder in terms of hemophilic arthropathy, or it can be infective complications as a function of treatment. Then comorbidities are important to consider, and venous access is also always important because you want the patient to get the treatment before and after surgery, and you don't want a problem with venous access. So what are the preoperative screening tests that we do? And these are the ones that are included. Full blood count and platelet count are very important. We also want to see that the coagulation system essentially is intact. And for that, we do the fibrinogen and prothrombin time. So the only variable that will be abnormal then is activated partial thromboplastin time as a function of low factor 8 or 9. Liver function is important, and especially if patients have been infected with hepatitis C. Renal function remains important, especially in elderly patients. And then HIV serology, viral load, and CD4 cell count should be considered, especially if you have a patient that is going to undergo arthroplasty, and you want to know whether the patient is at risk of also getting infection. Hepatitis C and viral load for hepatitis C is important, and then the inhibitor status of the patient that you can assess by doing factor 8 inhibitor or factor 9 inhibitor. And always this should be done, and should be done within the 2 months before surgery. But there are other ways of also, if the patient has low titer inhibitors, it won't always be apparent if I do a Bethesda assay. And what is recommended is that in vivo recovery study should be performed. And basically what we do is the patient gets between 25 and 50 international units per kilo dose. Samples of blood are drawn before the infusion of the factor concentrate and 15 minutes after infusion for comparison. And the way that I've been doing it is in vivo recovery as a percentage. So the factor 8 level after the surgery, and from that you subtract the factor 8 level the factor 8 level after the infusion, and you subtract the factor 8 level before the infusion, and you can then divide it by the expected rise in the plasma factor 8 level is expressed as a percentage. And if it's close to 100% or even greater than 100%, you know that the patient probably doesn't have an inhibitor. But there's another way to do it, and that's called the incremental in vivo recovery. And it's expressed as international units per deciliter per international units per kilogram. And how it works is that you do the factor 8 level, if you do this for factor 8 as a baseline, before the infusion, and that gets subtracted from the post-infusion factor 8 level, and then you divide it by the dose that has been given, the infused dose in international units per kilogram. And for factor, to be safe, for factor 8 deficient patients, you should have a value of more than 1.5 to commence the surgery. And in fact, it should be around 2. You can use a 15, 30-minute or 1-hour specimen, depending on where you get the highest value following the infusion. Of course, one should always consider a pharmacokinetic analysis to determine the clearance, recovery, and biological half-life to a challenged dose of factor concentrate before surgery. And this can be done in the conventional way, in which a dose of 50 units per kilogram is given before you take a factor 8 level, and you do it at different time intervals for up to 48 hours following the infusion. Or you can do it in a Bayesian way, in which you do limited sampling, 2 to 3 samples that gets taken following the infusion. And what is important is the half-life, because that allows you to evaluate the time interval between the 2 doses, so that you can maintain a adequate level of circulating factor 8. So the dosage and duration of a clotting factor concentrate is important, and the hemostatic cover depends on that and the type of surgery that you perform, major or minor. The problem is that the classification between major and minor is not clearly established. So there are different definitions. The World Federation of Haemophilia guidance says that for major surgery, you will require more than or equal to 5 days of hemostatic support, whereas the level of surgical invasiveness as a defining factor will define major surgery as surgery in which you have general anesthetic or spinal anesthetic, or where you require respiratory assistance, or abdominal surgery, or penetration of a major body cavity, or extraction of more than 3 teeth, or the 3rd molar teeth. So those will be some of the guidelines. And then in clinical trials, they will go for moderate or deep sedation, or the requirement for general anesthetic or major nerve conduction. So there are different definitions, and I think that the jury is out, because this is certainly something that is not entirely agreed upon, and there's no consensus about the definitions of major and minor surgery. This was taken, this table, from a literature review that's evaluated how surgical procedures in people with hemophilia were categorized as major or minor surgery, and they also assessed the consistency across publications. And what they found in the literature review, what it highlighted, was considerable variance in the categorization of surgical procedures, and there was overlap of some procedures. And as you can see here, for major surgery, when we think about general surgery, it's anything that's ectomy or otomy. So that will be prostatectomy, for example, or osteotomy, resection of a pseudotumor, and then orthopedic surgery, as you can see, all of these types of surgeries. But you will see that there's an overlap. Arthroscopic synovectomy is also appearing as a minor surgery. Central line insertion or removal, which is considered to be a minor surgery, is also sometimes considered to be major surgery in some series. So there's definitely overlap. So the recommendation in terms of replacement therapy of the World Federation of Haemophilia is represented in this table. But there are 2 things that are worrisome in here. So the first is that it speaks about peak factor concentrate, or peak factor levels. And that is good for the preoperative, but it's not good for post-operative follow-up, because it is actually the trough value that you are interested in. The second thing is that it speaks about lower dose practice patterns versus higher dose practice patterns, but there can only be one optimal type of care. So, and I know that the World Federation has motivated why they continue to put this in, but I think it's something that we need to consider too. So this was also an earlier publication by the World Federation, and you can see this makes it much more clear in terms of what needs to happen. So 120% is higher than what we are seeing now as a recommendation for major type of surgery preparation. But what it goes on to say is that we should maintain trough levels for the first 72 hours at 60 to 80. And then up to 14 days, we should maintain a trough level of 50. And then up to 3-4 weeks, a trough level of 30 to 40. And we should continue to give factor concentrate to a total of 40% international units per deciliter before physiotherapy. I think this is also a helpful type of publication or monograph. Of course, the factor can be given by bolus dose infusion every 12 hours or by continuous infusion. If you use continuous infusion, you can give it at 2 international units per kilogram per hour for adults and 4 international units per kilo per hour for children. Of course, you require a bolus therapy. So first you have to give a bolus infusion so that you get to a value of 70%, where after immediately you start with your continuous infusion. The continuous infusion continues for 72 hours at the same level, where after the dose gets changed to maintain a trough level activity of 50%. And usually after 72 hours, the continuous infusion is often changed to a bolus dose infusion. It's been said that continuous infusion may result in less coagulation factor use than bolus regimens or bolus dose infusion. And this is one publication that shows that in terms of the open squares is a bolus dose infusion and the solid squares are continuous infusion. You can see that in the post-operative days, the consumption of factor VIII was less. What about monitoring? And I think this is important, that we should do trough levels of clotting factors, and that should be done prior to subsequent infusion. And usually it is once a day during the first 2 to 3 days and less frequently thereafter. And what we do is we just want to see that we are on target. And therefore, if we've done it on the first and the second post-operative day, we discontinue the monitoring because we know that the patient is responding the way that we expected. Also, sutures that are removed or drains that gets removed or physiotherapy should be, these maneuvers should be coinciding with the time of the peak levels. And then continuous infusion, if the patient is receiving continuous infusion, you should do the level and confirm that you are on target within 6 to 12 hours of starting the infusion and then daily thereafter. When we talk about pain management, intramuscular injection should be avoided, of course. And then the post-operative, and I think this is very important, post-operative pain management should be coordinated with the anesthetist and a pain specialist. And it is very similar to patients that do not have hemophilia. So intravenous morphine or other narcotic analgesics followed by oral opioids and then paracetamol, and you can use COX-2 inhibitors. What is important though, and that should also be communicated with the ward personnel, is that you can use more and that the patients may require more analgesics than patients without hemophilia. And then in terms of thromboprophylaxis, this is controversial. And if you look at thrombosis, it's mostly associated with factor VIII bypassing agents in patients with inhibitors or with PCC. And I think that if we look at thromboprophylaxis, it is rarely used. And it's more conservative type of management in terms of pneumatic calf pumps and graded stockings to prevent thrombosis in patients with hemophilia that undergo surgery. If you are using PCC, you should give the patient anticoagulant. And if you use thromboprophylaxis, and that is the World Federation of Hemophilia guideline, you should use adequate factor replacement therapies. Okay, I think I am going to just go through these slides quickly. I don't want to discuss them. There's one slide, the last slide, that I would like to discuss, and this is a Cochrane review, where the treatment for preventing bleeding in people with hemophilia was assessed. And they looked at different regimens, durations of different surgeries. And unfortunately, there was insufficient evidence from randomized controlled trials to assess the most effective and safe hemostatic treatment to prevent bleeding in people with hemophilia undergoing surgical procedures. So I'm just going to conclude to say that we can perform surgery in people with hemophilia if we have adequate laboratory support, if we have a careful perioperative plan, when we have appropriate hemostasis with sufficient quantities of clotting factor, and that we have an optimal post-operative recovery and rehabilitation. So surgeries in people with hemophilia the surgeries have been successfully performed, but I think there are more research required for us to decide what is optimal duration and levels of treatment, and especially with the newer drugs that are being developed. I think that this is open for development, and I'm happy to take questions, but I'm not going to do it now. I'm just going to stop sharing my screen, and then I'm going to ask Dr. Pierkowski to show us the cases that he has prepared.
Just going to share my screen. I hope everyone can see my title slide. Can I just confirm if you can see it?
Yes, we can see it nicely, Mohammed.
Then, great, thank you so much. All right, so I was tasked with doing some data mining on some historical cases and preparing them to today's deep dive. I'm saying hemophilia, so probably going to look at any case and interpretation cases. Let's dive into our first case study, who I call Mr. A.E., and he's a 55-year-old male who weighs about 104 kilograms. He has severe hemophilia.
Dominic,
Yes? Yes, Johan?
I think you have an unstable internet connection, because it may be me, but it sounds troubled. Okay.
All right.
Go ahead. Go ahead.
Is anyone else experiencing that problem?
It's now a bit better, Dominic. I also heard it.
Sure. All right. Let me carry on then. So Mr. A.B. has no family history of hemophilia. He has been diagnosed with Intron 2022 version, and he is on 1,500 international units of cogonate at the time of this case study, which he used on a PRN basis, using approximately 12,000 international units per month. And his condition has been complicated by hemophilic arthropathy of the elbows, ankles, and the right knee. Right knee, in fact, had a right knee replacement. And at the time,
Dominic, we have lost the audio entirely.
this case study, his problem was primarily in the left ankle with formation. Yes.
Sorry, the audio is really
Can you?
bad.
I mean, is it possible perhaps that somebody else discusses the audio, the slides, because it's like your bandwidth
Yes.
stops.
Can you hear me, Estelle?
Yeah, perfectly.
Okay. So I'm going to just tell you when you should move the slides along. Is that going to be okay, Tomek?
That's fine.
Okay. So in terms of the left ankle, there were marked erosions and destruction of the tibio-talar joint. And there was also erosion and sclerosis and subchondral cyst formation in the tibiocalcaneal joint. And the patient is HIV infected and has been since the 80s because of blood product that the patient got, but he was well controlled on highly active antiretrovirals. He's also hepatitis C positive. He had genotype 2B, which failed eradication 3 years before the surgery. The eradication was attempted by pegylated interferon ribavirin, and the patient had extended therapy for more than 52 weeks, more than a year, and was unable to eradicate the hepatitis C. He's immune against hepatitis B as a result of immunization, and he was booked for elective arthrodesis of his right ankle. Next slide. And this is just an image, basically. Unfortunately, it's not very clear, but you can see that there is basically destruction of this ankle. And the patient didn't have range of movement around this ankle. Anyways, it was only pain. And therefore, arthrodesis was the appropriate type of surgery for him. Next slide, please. So I think the general considerations for all patients that undergo surgery is that the surgery should be coordinated with the experienced hemophilia management team. And I think that is what we tried to show already in the previous discussion. The surgery should be performed with sufficient lab support on site. So we need to be able to do factor 8 and 9 levels, and we need to also do inhibitors, and we need to do that also after hours. So the lab should also know and be informed of the surgery that's taking place and the support that we require. Inhibitors has to be excluded, as we already said, and there's more than one way to do that, both with formal testing, Bethesda assay, but also in terms of in vivo recovery to do a more complete assessment, and then possibly also PKs with half-lives. Surgery should be performed early in the week and early in the day to ensure that there is ample lab and blood product support. And then availability of adequate factor concentrate should be confirmed prior to surgery. I don't want to do any surgery if the factor replacement therapy is not on the shelf. It needs to be already available. It shouldn't be on back order. You're going to run into trouble. Next slide, please. So in terms of the preoperative workup, and I think there are quite a bit of special investigations, the patient, we do a full blood count and of course platelet count, and then the coagulation studies, PT, and the fibrinogen level. As you can see, the only abnormal result was the activated PTT as a function of basically factor 8 deficiency in this patient. We do a UKNE and a liver function test, and especially in this patient. So the essentially normal UKNE, but in this patient, we were always worried about the synthetic liver function, and we would like to know that the albumin is normal, and that the patient has, and we've already established that the INR is entirely normal in this patient. So the synthetic liver function needs to be assessed in a patient that has hepatitis C and that you don't know how far advanced the hepatitis C is in terms of liver involvement. You can see mildly deranged transaminases. And then, of course, you can see a high viral load, of course, unable to eradicate this infection. Next slide. Okay, and then the CD4 cell count, so well reconstituted CD4 of 686 with a viral load that was low, less than 150 copies. And I think that that is perhaps the detectable limit of the assay. Next. And we also did the formal factor VIII inhibitor Batista assay, and it was 0. So having considered all of that, I think one can go into the treatment plan. So we did do in vivo recovery. The patient got a dose of, just as in addition to the Batista assay, to confirm the absence of low titers of inhibitors. So 250 international units is what we gave the patient. The pre-infusion factor VIII level was 1. The post-infusion was 53. And then if we basically do the in vivo recovery incremental, we get to a value of 2.2. And since it's more than 1.5, we are happy. This is where it's supposed to lie in terms of recovery. So the post-infusion factor VIII, you subtract from that the pre-infusion factor VIII, and you divide it by the dose that you've given in terms of international units per kilogram. Next slide. So minor or major surgery, and we've seen it in the previous presentation, that this patient now gets arthrodesis of the ankle, and that is a major type of surgery. All orthopedic surgery, as far as I'm concerned, apart from radiosynovitis, synovorthesis, or injection of cortisone and anti-inflammatories, are, as far as I'm concerned, major types of surgery. So, and we already discussed that there is a lack of consensus in terms of what constitutes major and minor surgery. So the preoperative management plan for this patient, we considered this as major surgery, of course, and then we wanted at the incision time the level to be 100%, which means that if we just do a simple calculation, it will be 50 international units that are given per kilogram, and that should take us to 100% with 100% recovery, in vivo recovery. So the patient was supposed to receive 5,000 international units as a bolus injection, 15 minutes to 30 minutes before the incision time. The patient weighs 104 kilograms times 50. Okay. So in terms of that, the peak is very important because that will prevent the bleeding. But in terms of post-operative management plan, this is what we talk about maintenance. And for that, we need the trough levels to be at the sufficient level so that the patient doesn't bleed. So factor target levels for the first basically 1 to 3 days should be between 60 and 80%. And then for the next 3 days, 40 to 60%. So an average of about 50%. And then up to day 14, we would complete about 40% target. We would measure the daily measurement of the trough factor. That's important for us to check that we are maintaining a trough level that's acceptable. And then we need to know that there are various methods available for us to reach a target. You can change the infusion. You can do continuous infusion. You can change the frequency of dosing. And I know that a lot of people in the audience would say, I give 100% at the time of surgery, then I take that 100% and I divide it into 50% PD. And that is one way of doing it. Or you can do frequent dosing, where you do 3 times a day for the first 24 hours, and then followed by PD dosing. So for this case, we chose frequent initial dosing, and we gave the levels. I can't remember if we gave the levels in this individual case every 6 hours for the first 24 hours or every 8 hours, but we will gradually increase or decrease the frequency of that as we go along. So, and it says the trough or peak, and that is the guideline of the World Federation, and it should be peak level at the time of surgery and trough level for your maintenance. So I think that's important. Next. So we use a different formula for calculating the daily factor 8 requirements. And what we use is the what I've already said, clearance, which is 3 milliliters per kilogram per hour, which is the mean clearance for factor 8, times the target where we want to go. So that will be in international units per deciliter, but it's the target is expressed as 0.8. And that is what you're going to use if you use continuous infusion. The clearance times what your target is, multiplied by your target. That's your clearance, but that is your continuous infusion per hour. But we want to calculate it for the patient, 104 kilograms for 24 hours. So what we calculate in this equation gives us the total factor 8 requirement that the patient is going to use or require per day if we want to target 80%. So the first 3 days. And then we get to a value of basically 6,000. If we now give that 3 times a day, so it will be 2,000 basically TDS every 8 hours. Or you can then use that into 3,000 PD if you wanted to do that. So should we use actual weight of the patient or should we use ideal body weight? We know that in patients that are obese, that the volume of distribution is less and that they are better anticoagulated if you dose them by total body weight. And I think the jury is out. There is no conclusive recommendations as far as I know in terms of whether to use ideal body weight or total body weight. But I think ideal body weight is probably the way to go. So next slide. Yes. And then this is how we managed in the first 24 hours. We gave the patient 6 hourly. So we took the dose and divided it by 4. So that was 6 hourly. The next 24 hours, we gave the dose 8 hourly, and then we went to BD dosing for the remainder of his rehabilitation. Next slide. So that's actually what we did. And then the targets reduced as we go along. So we continued up to 14 days. Thereafter, we continued with 1,500 daily up to day 21. And that is what typically happens in Europe. They cover the patients for a month, and then the patient go back onto his prophylaxis. So once you stop giving the patient cover in terms of maintenance, you should still know that the patient could require at the time of physiotherapy cover, and you should increase the factor 8 level to 40% to coincide with the physiotherapy sessions. Of course, the doses of factors should be adjusted on an individual basis, and you should ensure that the trough levels are adequate. And we basically do that day, the factor 8 levels daily for the first few days, and just check that we're on target. Thereafter, we know that we can continue. Next slide, please. So we've already discussed this, so I'm not going to spend time on this, but I think that's important to know that you can use tranexamic acid, and that you have to see to it that there's adequate pain relief for patients. And this is what we found in terms of the day 0, the patient was at 94 international units per deciliter. Day 1 post-op, 117. These are trough levels. And the second day, 112. And thereafter, we adjusted these values downward to get to the target. So we initially have over replaced this patient. but the outcome has been really good. There you can see the post-surgery x-rays that were taken. And you have to also document the outcome in terms of your surgery. And our patient had an excellent outcome, which means we didn't use any unplanned factor VIII or other agents to ensure hemostasis. And the patient didn't require any blood transfusion or similar treatment. So we are happy with the outcome of this patient. Next slide. Case study 2 is an 8-year-old male patient that weighed 32 kilograms with severe hemophilia A. He has a family history. He's on regular replacement therapy, and he was using cogenate FS at the time of the surgery, 1,500 units of factor VIII 3 times a week, and he was well controlled. This patient hasn't had a bleed for many, many years before the surgery and subsequent to that also. His disease has been complicated by neonatal intracranial hemorrhage, and the patient also has hemophilic arthropathy of his right ankle. He's immune against hepatitis B as a function of immunization, and he was booked for right ankle surgery. And it was actually a debridement, open debridement of his right ankle. Next slide. Unfortunately, these x-rays aren't the best, but there was avascular necrosis. Yes. In subchondral, there was an osteophyte. There was also a loose body in terms of cartilage in the joint that hampered movement of the joint itself. And there was erosion of the articular surface of the mortise on the right ankle. So the patient had a lot of pain and discomfort, and on occasions the ankle would lock because of the foreign body in the joint space. Next slide. So the full blood count in this instance was normal, a platelet count of 282, and the patient wasn't anemic. The liver function was fine with a normal synthetic function, of course, and the patient didn't have inhibitors. And we did do in vivo recovery of the cogenate. We gave 1,000 units. The pre-infusion level was 2%. Post-infusion level was 64%. And when we calculate the in vivo recovery incremental increase was 2. And so we were on target, and we were happy to proceed with surgery. Next. We classified this as major surgery again. It was open surgery, even though it was just a debridement. And in fact, even if I think about arthroscopy of a joint like this, certainly the people in Italy think that it is major surgery, and I won't think differently. So what we would like to do, factor VIII level of 80 to 100% at the time of incision. So we gave 1,500 units as a bolus injection 15 to 30 minutes before the incision time. So when you calculate that, it's 50 times international units per kilogram, and that will, you just basically use the closest file to what your calculation is, and probably take it up rather than down. Okay, next, yes. So in terms of post-operative, we aim for a level of about means, again, 70% day 1 to 3, 50% day 4 to 6, and then 40% for the remainder of 14 days. And then the daily levels, we measured the trough levels in this patient. So the maintenance that was given for the first 24 hours was basically given 6 hourly, and that was 500 units. For the next 24 hour, we gave it 8 hourly at 750 units, and for the next 24 hours, 2,000 international units BD. Next slide. So that's the first 3 days post-operative. And then for the next 3 days, we just use it 750 BD, so reducing the dose. And for the next week, basically 500 internationals BD. Thereafter, we went to 500 up to day 21, and then the patient went back to his regular replacement therapy in terms of the cogenate as a prophylaxis. And of course, he continued to coincide those infusions with physiotherapy post-surgery. Same thing applies to all patients in terms of adjuncts. Tranexamic acid was given to this patient. He had a topical fibrin sealant that was used intraoperatively. We did his post-op, so day 1 surgery, 115%, so we were on target. Day 2, it was still high, and then we adjusted the dose to day 3 to 70, which was on target. So it's downward titration. So the clearance that we use in this instance is 4 milliliter per kilogram per hour, because children have a higher clearance. And again, the patient had an excellent outcome reported. So that's exactly what we want. We don't want, when we prepare patients for surgery, we don't want to run into troubles, and I certainly don't want any surprises in theater or beyond. Next slide. This is the last case. It's a 26-year-old male that weighed 50 kilograms with severe hemophilia B, and he used 2,500 international units of Hemasolvex as necessary. So he was on episodic therapy, and he didn't bleed too frequently. So he had a recent laparotomy for bowel obstruction, and he had excellent outcome in terms of the treatment plan that we devised for that surgery. So he was now booked for the tonsillectomy. Next slide. So in terms of this, you do see that the patient does have a red cell count that's a little bit elevated, and also microcytic hyperchromic, albeit moderate values. So one wonders about the possibility of a carrier, for example, for something like thalassemia in terms of this. But the RDW was a little bit wide, 18.9. But in terms of surgery, the patient wasn't anemic, and the platelet count was normal, 291. Next. So the PT was normal. INR was 1, 10.4 seconds. Synthetic liver function was fine, and the patient had essentially normal liver function. So we didn't do a recovery in this instance because it was done with the previous surgery, but we did do factor 9 inhibitor levels, and they were negative. Now, a lot of people in the audience will disagree that this is major surgery, because tonsillectomy here really it's minor surgery. It is minor surgery, but it is high. It can complicate, and we can, and it's often seen that the patients have post tonsillectomy bleeding. And if you think about this, there was a recent series that was published in terms of tonsillectomies. And even if you look at a European survey that was done, patients consider this to be minor surgery, but they almost invariably treat patients for 7 days and even longer sometimes. And the post tonsillectomy hemorrhage can happen any time up to 14 days, and it usually happens in the first 14 days. So in terms of this, we consider it to be major surgery, but certainly that is not what literature suggests. So we wanted, again, at the time of incision, a level of about 70 international units per deciliter factor 9. Remember that we're using PCC in this patient. So you always have to be cautious when you use PCC. If you use high doses and you have an intensive treatment period, that you don't cause thrombotic phenomena. So we are more conservative when we dose patients with PCC than with a pure factor 9. So the patient was supposed to receive 4,000 international units as a bolus injection before surgery, and that is basically the 80% that we target times his weight, 50. So that's 1 international unit per kilogram gives you 1% factor 9. No, increase of 1% factor 9. So in terms of post-operative, we maintain these factor levels for the first 1 to 3 days with a target of about 50. Following day 4 to 6, a target about 40, and then day 7 to 14, a target about 30. So daily trough levels are recommended, and we've done 1 trough level. So for the first 72 hours for this patient, we're using 3,000 international units, and now you use it daily because the half-life of factor 9 is longer. So it's no BD dosing that we've seen in factor 8, of course, and we give it once a day only. And then we reduced it to 2,500 units for the next 72 hours, and then thereafter 1,500 units. And then the patient had some prophylaxis until the wounds are fully healed. So, and that is usually quick. So by day 14, the wounds were already healed, and the patient didn't commence to using prophylaxis and went back to his basically on-demand episodic use of the PCC. Yes, next. And of course, tranexamic acid is very important in specifically this case. And you can use it as a local agent. Patients can use it systemically and as a local gargle. So it's difficult. You have to crush it and you have to dissolve it, but it doesn't dissolve well. It is difficult to crush, but it works miracles in patients like this. I wish we had a different form of tranexamic acid to use. So good surgical technique is very important, of course, in this patient also. Next. Next. And the patient really did well. There was no post-operative bleeding. There was no infection in the wound, the tonsillar beds. And again, this was an excellent outcome when the perioperative hemostatic function is graded. Next slide. Okay, that's the last of that. You can stop sharing, please, Tomek. Thank you so much. And then I just want to confirm that Mohammed is in the audience.
Yes, Mohammed is ready to go.
Please, Mohammed, you can share your screen, and I'm happy to listen.
Thank you, Jan.
These cases were amazing. That's all I can say while we wait for Mohammed. So let's hear about the inhibitor patients.
Good afternoon, colleagues, friends. Thank you, Jan. First of all, Estelle, can you hear me? And secondly, can you see my slides?
Yes.
It's not in the presenter mode,
No,
Mohammed.
you can put it in presenter.
How's that?
Perfect.
Okay, so thank you for inviting me on. So I'm going to speak on perioperative management of persons with hemophilia who have inhibitors. Before I start, actually, Estelle called me last week, Thursday, I think, and Estelle said, listen, you need to send me a bio, and you can include your career, and it doesn't have to be only your career, you know, you can include things that you're interested in. And I'd like to say, Estelle, thank you very much, because as a result of that exercise, I realized that I'm not very interesting. But let me see if I can inject some interest in this topic. So we're going to talk about the practical aspects of treating these patients with inhibitors, the general preoperative assessments, the intraoperative assessments. Hopefully we can get to the general post-op care. And I'm going to be concentrating on the bypassing agents, of course. I'll touch a little bit on the alternate therapies and a little bit on thromboprophylaxis. I'm going to not dwell too much on the general aspects because Johan, of course, covered it expertly. And I'll maybe touch on just a few things. So We know that hemophilia is an X-linked congenital bleeding disorder. It results in, of course, a deficiency in factor levels, often factor 8 and factor 9. And as a result, of course, these patients have significant bleeding. It can be either spontaneous or traumatic bleeding, and they bleed into joints, muscles, organs, etc. Now, this requires, of course, that they be treated with affected infusions to either prevent the bleeding or to even stop bleeding. But of course, this isn't the case in patients with inhibitors. Now, inhibitors occur in about 20 to 30% of patients with severe hemophilia A, and in up to 6% of patients with severe hemophilia B. And these are alloantibodies which neutralize, of course, the effector and render the effector then ineffective. And hence, we need to have another approach. Now, it is the most serious and definitely the most costly complication of hemophilia, which results, according to studies, in a 2-fold increase in hospitalizations, a 10-fold increase in cost. Of course, this is probably related mainly to the bypassing agents, the duration of stay in hospital, etc. And importantly, of course, a 3.5-fold increase in mortality. So for practical and management purposes, we like to designate these patients into 2 groups. Those are the low responders who have less than 5 Bethesda units of inhibitors, and of course the high responders. And the reason, of course, for this is that the low responders can be treated with high doses of factor and don't necessarily require bypassing agents. Now, just a short 10, 15 years ago, patients with inhibitors in hemophilia were not actually given the option of surgery. They were often denied surgery. Major surgery was often not, given to them, and even procedures like diagnostic procedures. Now, with the advent of the bypassing agents and experience over the last 10, 15 years, surgery is definitely now feasible in these patients, but it's not without these risks. Firstly, the bypassing agents are not as effective as your factor replacement therapies. There is a failure rate of about 10 to 20% in these patients. And in addition to that, there is a higher risk of infection. It's proven, in fact, and we'll see maybe if we have time in orthopedic patients, that there is a higher risk of infections in patients with total knee replacements and inhibitors versus their non-inhibitor counterparts. Now, as Johan said, of course, the one proviso is that this has to be done in a hemophilia treatment care center and of course, using a multidisciplinary team. And Johan showed you this here. And of course, all of these people are important, as Johan expertly illustrated. Now, the genital preoperative assessment, apart from the additions, apart from what Johan said, I just add a few more things perhaps, is that this should be done timeously and early, and this goes without saying. So at least 2 to 3 weeks prior to surgery, the core team, which includes the hematologist, the hemophilia treatment nurse, the social worker, and the physiotherapist, this is the core team, should at least interview the patient and come to the conclusion whether the patient is appropriate for surgery or not. Now, if the patient is appropriate, the hematologist should then pen a detailed treatment plan. This will include the duration and dosage of the hemostatic therapies. This will be post pre-operatively, intraoperatively, and post-operatively. The person's surgical readiness needs to be assessed. What was the outcome of previous surgeries, perhaps? What is the compliance of the particular patient? What is the goal? What does the patient expect out of this? Of course, the laboratory investigations that Johan talked about, and I'm not going to go through all of these things again, except that perhaps a thrombophilia workup may be required. So if somebody has a history of thrombosis or a family history of a thrombophilia, then in this case, a thrombophilia workup would be beneficial. The pain management team, of course, that we talked about, dental evaluation that Johan mentioned, particularly in patients who are having prosthesis or those who are having the central venous access devices. Those will be important. Physical therapy. Intravenous access is something that we don't often give thought to, and particularly in these patients, it should be definitely thought about. Are we going to put a central venous access, a CVAD device? Are we going to use a PICC line? This would make it easier, of course, but this must be then offset with the potential detrimental effects, and that is primarily infection. So that's one decision that needs to be made. The social worker, unfortunately, ladies and gentlemen, we do need the surgeon. and not just any old surgeon, preferably a surgeon who is well-versed, and with all due respect to my surgical colleagues, well-versed with treating patients with hemophilia in terms of the surgical techniques, etc. With regard to the timing of the surgery, again, something that seems a minor thing, but is important. This should be done preferably early in the week and should be done preferably early in the day. And this is mainly because of the availability of, one, the laboratory investigations, and two, the treatments, so the medications and drugs that are required. So how do we maintain hemostasis or achieve hemostasis in these patients? As we said earlier, for management purposes, we divide them into these two groups, the low titer or the low responding inhibitors, and those are less than 5 Bethesda units. And of course, these patients are those who can be treated with high doses of factor, be it factor 8, factor 9, and this is to overcome these inhibitors. And I'll show you the doses a little bit later. The concerns here, however, is the following one: a high dose of factor 9 can increase the risk of anaphylaxis. And I think even more importantly, probably, is this anamnestic response. And after giving, of course, high doses of factor to a patient already with inhibitors, this may trigger an anamnestic response in the inhibitor titer. And this can occur actually within days, 1 to 2 days. And this will then necessitate a switch to a bypassing agent. Are there options for these patients? Of course, immune tolerance therapies, rituximab, these are options. And the problem here is that you need time. The cost may be an issue. And of course, with rituximab, and also with immune tolerance regimens, the potential for infection. So these need to be considered. High titer inhibitors, these patients need bypassing agents. And of course, we have two different ones that we know are registered and available for use here. That is NOVO7, recombinant activated factor 7, and FIBA, which is an activated prothrombin complex concentrate, in APCC. Excuse me. The choice of this particular product will depend on a few things. The patient itself, the age of the patient, was there prior exposure to plasma products, the type of bleeding episodes, the volume of reconstitution, in our case, the cost, of course, the efficacy and safety, and also, which I didn't add there, is the product that the patient was using already and whether there was success with that particular product. And I think that will be one of the most important things, actually. Now, let's look at these agents a little bit more in depth. FIBA, which is factor 8 inhibitor bypassing agent, it has been used in more than 200 surgical procedures in studies that have been published, with a hemostatic efficacy of 78 to 100%. However, in all of these studies, the initial doses, the frequency, and the duration of treatment were variable, and continuous infusions were not studied in FIBA. The Norwegians, of course, have a very good record with hemophilia and have an extremely good program. In their records, they have 37 surgical procedures, of which 17 were major. And they delivered the APCC by a bolus infusion over 15 to 20 minutes and given every 8 hourly. They gave pre-op loading dose of 100 international units per kg and a total dose of 200 international units per kg per day for the first 72 hours. Following the third post-op day, they then reduced the dose to 150 international units per kg. And from the 7th post-op day, they reduced it to 100 international units per kg. Thereafter, every alternate day, they gave 50 international units or prior to physical therapy. And what they found was that there was a good or excellent hemostatic outcome for minor procedures. And in fact, in major procedures, the response was 88%, so 15 out of 78% had achieved excellent hemostasis. Now, let's look at NOVO7. There are quite a few case series in the literature. They include a small amount of patients, but generally they showed a good hemostatic outcome. There were two small prospective randomized trials, however, one by Shapiro and colleagues in which there were 29 patients with inhibitors, and they included patients who undergo both minor and major ops. And what they did was they gave the patient a pre-op bolus, and then randomized them to two groups, the 35 microgram per kg, and you'll note that that is less than half the general dose we use, which is 90 micrograms per kg. And this was given every 2 hours for the first 2 days. And then thereafter, they went to 2 to 6 hourly for the next 5 days, depending on the individual patient. And what they found that in major surgery on day 5, with the low dose, hemostatic efficacy was 40%. but 83% for the high dose. And they therefore concluded that the dose that should be used for patients with major surgery was the 90 micrograms per kg dose. In minor surgery, the efficacy was 70 to 100%, respectively, for the low and higher doses. And I suppose one would probably want to go for the 100% efficacy and probably use the 90 micrograms per kg as well. There were some other studies. So this particular study by Pruti and colleagues showed, looked at 22 major surgical procedures, and these were both hemophilia A and B. And what they did was they gave a bolus dose of 90 micrograms per kg, but they then randomized patients to two groups. The one was the bolus infusions every 2 hourly, and the other was the continuous infusions. And this was 50 micrograms per kg per hour, and given for the first 5 days. And they found basically comparable hemostatic efficacy and safety, and except that they were considered ineffective treatment in 3 subjects in each arm. So those were equal in both arms. So suggesting that both the bolus route or the continuous infusion route had a equal or similar response with similar safety that you can see there. Now, Valentino and colleagues looked at the hemophilia and thrombosis register, and they looked at a small number of medical procedures, including surgical and dental procedures. So in total, 395 cases in which 84% of patients achieved an effective response using Novo. So this establishes that Novo is effective, of course, for perioperatively for patients with hemophilia with inhibitors. And interestingly, or importantly rather, the thromboembolic complications were very low, and they reported less than 0.02%. So having said all that, this is an algorithm to basically assist us in how to manage these patients after looking at the general expert consensus. And this is as follows. So patients with hemophilia A who are low titers, as we spoke about, can get high levels of factor, and that's 100 units per kg. And you'll note that that is probably double the dose that Johan was alluding to earlier. Those who have a high titer, if they are plasma naive, so haven't received any plasma products, we will prefer to give them Novo 7. Those who are plasma experienced would prefer to give them the FIBA. In hemophilia B, we will use recombinant factor 7 Novo, and at the same doses. And this is an idea of this is the doses that we generally use. And let's focus rather on the intermediate and major surgery. So in intermediate and major surgery, there should be a pre-op dose, and this is for FIBA of 120 international units per kg and given every 2 hourly. And you'll note that over the next 5 days, the dose should be reduced. Of course, this is dependent on the clinical response. Unlike, unfortunately, and I may show you a little bit later, in the patients without inhibitors, one can, of course, do the factor levels. We don't have that liberty here. And so clinically, we'll be guided clinically. So on day 1, of course, they'll get the full dose of 90 to 120, and then 3 hourly from day 2, and then 4 hourly from day 3 to 5. And from day 6 onwards, they'll get 90 to 120 micrograms per kg. And one shouldn't forget, of course, as we said, the treatments pre the physiotherapy sessions. And of course, continuous infusions, the dose is there that you can see. With FIBA in major surgery, one should give a loading dose of 75 to 100 international units per kg, and then use that same dose 8 to 12 hourly for the first 5 days. And from day 6 onwards, the similar dose, but 12 hourly. And according to clinical response, one can of course reduce these doses. This is the Nordic guidelines. I just put it here for your reference. We said earlier that they have very established hemophilia treatment centers and treatment guidelines, and I included this is very similar, except that the reduction of the doses is a little bit different over the first week. Essentially, the idea is the same. So what do we do with patients who have been given their hemostasis agents, and despite the doses that were, the effective doses were given, they still have unexpected bleeding or postoperative bleeding? So if we follow this algorithm with me, we give them the initial bypassing agent, and if they respond to it, that's great, and we decrease it as we shown a little bit earlier. But if they do not respond to this dose, we then increase the dose to the maximum dose. So for example, in the case of FIBA, one can go to the full 200 international units per kg per day and then monitor. If this is effective, great, we reduce after the 5 days, or in the case of Novo, of course, after 2, 3, and 5 days. If this is not effective, one then switches products. So this is actually important, because if you're going to undergo a surgery such as this, you need to make sure that you have enough product, and need to make sure that you have enough of the alternate product. Because once this happens and you switch products, you then see if it's effective, go to the, if it's not effective, go to the maximum dose. And if this dose is not sufficient, the maximum dose, then one should consider combined sequential therapy. And that is explained, and I chose this article from the literature, which is a few years, about 3 or 4 years ago. And this is one of the extreme cases in which this patient was a 52-year-old male patient with Haemophilia A, who had inhibitors. He had inhibitor titer of 40 or so, 45 Bethesda units. And this patient was actually planned for an elective central venous access device procedure. And the reason he needed this is because he was responding very poorly to the bypassing agents and required, prior to the surgery, required already sequential bypassing agents. And so prior to this procedure, he was admitted, presented with pain in the knee, and it was found that he had a septic arthritis, in which they cultured, in fact, some Klebsiella, and the orthopedic surgeons decided that he needed urgent intervention. So as a result, they decided to go with sequential therapy, and you can see here that they went extremely high dose. They started with Novo, 180 milligrams per kg per day preoperatively, and then they went for the 90 micrograms standard dose and the APCC of 5,000 international units, and they alternated this every 3 hours. And if you look at this, and I don't know if this projects very well, you'll see here on day 1, or for the first week. For the first week, they went with these alternating doses, as you see, of 90 of Novo with 5,000 units of the FIBA, and they went for a full 14-day cycle. And then on day 15, they changed to, as you can see there, 6 hourly, and then day 4 hourly. Day 28, they changed to 6 hourly. And day 42, they changed to 12 hourly. So I'm not certain who paid for these, for all of this factor, but definitely it was a significantly high amount. But what they did find was that in this patient with a poor record, poor hemostasis, poor hemostatic record, actually achieved a good result. So sequential therapy is something that one needs to consider. Now, I don't think we have a lot more time, and I don't want to hold you too much back. I'm basically going to run through these next few slides. I'm not going to talk much about it, just to suffice that these are alternative treatments. The recombinant porcine problem here is that, of course, the difficulty of access, which we won't have. There's a cost, and even the monitoring is a problem, and of course the experience. I think there's probably 1 or 2 cases only that have been done in patients with inhibitors using recombinant porcine factor 8. And then this is a product which was marketed, I think, or first marketed in Japan, called Biclot. Only 1 procedure was done using this particular product, and there was a reasonable success in that one. What about antifibrinolytics? Johan talked about this, and we know what antifibrinolytics, tranexamic acid, does. It increases the clot stability, of course, and can be used concomitantly. It shouldn't be used, rather can be used with Novo to improve hemostasis, but there isn't a lot amount of studies. In a recent review, in fact, in orthopedic surgery in patients with inhibitors, they suggested that tranexamic acid or cyclopentone be used concurrently. There was no increase in thrombosis, and there was good hemostasis achieved in that particular study. Now, with FIBA, it's not recommended to use this concurrently. There should be a lag time of 6 hours. Johan talked about this, of course, earlier, and the reason for this is the risk of thrombosis. Although one is not certain whether there's enough, studies, because as Johan also alluded to, there were series in which they used it without any adverse or increased risk of thrombosis. But wherever possible, one should use the topical product. So either is a mouth rinse, cyclopentone, or moisten the dressings, and one can use this together with FIBA, and this is considered safe. In the dose you can see there, 10 milligrams per kg IV or 25 milligrams per kg orally 3 to 4 times a day for the full 7 to 10 days. Thromboprophylaxis, again, we know that thrombosis is a concern with bypassing agents, but in this patients, given the high risk of bleeding, it is not recommended that we use thromboprophylaxis, except in individual cases. The non-pharmacological methods would suffice, so the compression stockings, demobilization, etc. I think, Estelle, we at 17:37, so we don't have a lot of time. I'm going to leave the intraoperative out and just maybe make a point here that the investigations, the PT and the PTT is limited here because, of course, it doesn't assess the clot stability and specifically the thrombin generation at the surface of platelets, which is postulated to be one of the mechanisms in which Novo works. And so we can't measure this. So that's a problem. Maybe we'll know a bit more in the future about TEG and the TGT. The important thing is to make adjustments to the hemostatic therapy, to, as we talked about earlier, perhaps change the agent, doses, etc. The surgical methods, the surgeon should minimize soft tissue dissection, perhaps use less invasive method like laparoscopic, but this should be then offset with the potential detriment of not being able to see clearly the bleeders, and of course topical hemostatic agents that we talked about here. These are specific things. I'll make this available to people in the future, and unfortunately I think I'm going to have to stop there. Thank you very much for the opportunity, and handing over to you, Estelle and Johan.
Thank you, Mohammed. And that has been comprehensive. I would, we are out of time, Estelle, essentially. So I see there are a couple of questions and comments in the chat. I just want to quickly take one of them. Dr. Mashihu says, thanks for the great talk. So the aim is not necessarily to achieve 100% rise prior to any surgical procedures. Since there's no clear consensus on major versus minor, unlike replacing based on site of bleed where desired rise percentage clear. And I agree with that. It is more of a ballpark thing than it is an actual value. But we are having an aim, and we do calculate specific values, and we would like to achieve those values, and that is what we work towards. So if I calculate 80%, I want 80% or more before I'm happy. So I think you have to have a target, and I think you have to chase the target as far as you can. Please remember to just register your attendance, and the link is there in the chat on the red cap. And then the last thing is, in the realm of gene therapy, and this was from Dr. Wang, would factor management be different for these patients perioperatively? And I'm not sure Johnny can perhaps speak to that, because I think he has most experience in terms of that. But if you think about high concentration of or high dose vector and normalization of factor 8 levels, for example, I don't think you need any intervention around surgery, and you probably need to look at thromboprophylaxis in patients that are older more than anything else. Johnny, I see your hands raised.
Thank you, Johan. Can you hear me?
Yes.
Yeah, no, this was actually quite educational. Maybe I could just make a general comment and then a few specific comments. The general comment relates to, I'm pleased that Pretoria academic has experience in surgery. I think it is high time that we put our surgical experience together and get these published. I mean, almost all of what we do is in reference to Europe, when in fact our own center has done just over 130 major and minor surgeries in the last 10 years. So I'm inviting all of those who have done surgery, who have not had the opportunity to do this kind of thing, maybe to do it, and so that we can share the experience amongst ourselves. Yeah. With regard to Ching's question, it really depends on the level at which one is able to get the vector post-gene therapy. Just to remind you that the current vector we use is AAV, and within 3 to 5 months, it's out of the system. So the way you handle patients post-gene therapy, certainly outside that window, is not different from any other patient that you would handle. And talking about handling patients and thromboprophylaxis, in our center, as I say, we've done just over maybe 120, 130 major surgeries. We do not use thromboprophylaxis. For the benefit of the registrars in this call, the main reason is because it doesn't matter how much replacement therapy you give, you never achieve the thrombin generation that normalizes completely. That's why we just never give prophylaxis, because we think that the hemostasis is not normalized. Of course, if the hemostasis is normalized, you will need thromboprophylaxis. I'm going to stop there. There are quite a few questions that I wanted to ask, but I realized that we've actually run out of time. But thanks again, Johan and team.
Thank you, Johnny. And with that, I would like to thank you for your attendance, and I bid you a good week, a good Easter weekend that lies ahead. And please don't forget about World Haemophilia Day on Sunday. Thank you. Bye.